respected delegates, we would like to invite you. We would like to invite you to AICOG 2017 Oration to be delivered by Dr. Murlidhar V sir on the topic of maternal near miss concept and audit need for of the hour to bring down MMR in India. We welcome you all to tonight's oration. For the oration, we have chief guest in form of Dr. Alpesh Gandhi sir and Dr. Dipesh Dodake sir. In form of guest of honors, we are having Dr. Hemant Bhatt sir, Dr. MC Patel sir, and Dr. Pragnesh Shah sir. To begin with, we would like to introduce Dr. Murlidhar V sir. He is at present Dean of Sikkim Manipal Institute of Medical Sciences, Sikkim, Professor of Obstetrics and Gynecology, Professor and HOD of OB&GY at KMC Manipal for the years 2016 to 21, MMMC Malaysia 2000 to 2007 for 7 years. He is founder and current chairman of Karnataka College of Obstetrics and Gynecologists. He has delivered 650 guest lectures, 195 publications, 13 Best Teacher and Teaching Material Awards, and 4 Best Research Awards. He has authored Holland and Bruce Obstetrics 4th edition and Obstetrics and Gynec PMFU 1st edition. Both were published by Elsevier. He has experience of 35 years of teaching, 30 years as an examiner for MBBS, MS, MCH, and PhD and DNB, as well as for FNB. We welcome you, sir, for tonight's oration. We would like to have few words from Dr. Pragnesh Shah, sir, guest of honor. Pragnesh, sir.
Dr. Murlidhar V sir, welcome to our very prestigious oration of AICOG 2017. We are very, very fortunate that orator is none other than a dean and an educator who really believes in auditing maternal near miss complication and bringing the maternal mortality in an area like Sikkim. I think he must be doing a great work, and we would like to learn from a lot of things that every medical college should be doing an audit in a constructive way. And that is what the theme of the today's oration is. Sir, stage is yours.
Thank you very much. Munjal, should I start the oration first?
Munjal sir, you are mute.
We would like to read out the scroll, sir, to confer the oration. The scroll says that Ahmedabad Obstetrics and Gynecological Society feels honored and has pleasure to award AICOG 2017 oration for the year 2021-22 to Dr. Murlidhar V. Pai, date 26th of March 2022, Saturday, on subject maternal near miss concept and audit need of the hour to bring down MMR in India. Dr. Jignesh Deliwala, President AOGS, and Dr. Munjal Pandya, Honorary Secretary AOGS. The stage is all yours, sir. Thank you.
First of all, I would like to thank you, Dr. Jignesh sir and Dr. Munjal, for inviting me and honoring me with this prestigious oration award. I also thank the guest of honor, Dr. Pragnesh Shah, who has come here, and Dr. Alpesh Gandhi, and all the dignitaries who are there for this oration. I would like to upload my presentation now, and I will start the oration. Well, so you can see this, right?
Yes, sir.
Yeah, okay. As I said, I would like to first thank the Ahmedabad Society for kindly inviting me to this oration. This is a wonderful place called Namchi, where we have Char Dham and big statue of Shiva in South Sikkim. I invite all of you to this wonderful place, Sikkim, once again. Okay, I'm going to show you an actual video of the 2 jumbo jet flights using the same runway. One jumbo jet is trying to land, whereas the other jumbo jet is trying to take off. Just watch yourself. A perfect recipe for disaster. One jumbo jet is trying to land, another take off in the same runway. A sure recipe for disaster. Can anybody guess what happened afterwards? Well, the intelligent pilot who was trying to land aborted landing and avoided the disaster. And that's when we say, oh my God, just missed. The aviation industry has one of the best trainings, better than doctor's training. Next time, before you fly, make sure that you check whether the pilot himself is going all around the flight or not. They check at least 17 points before they take off. They go around the flight and they will make sure that everything is fine. We also should train ourselves in that manner. 300,000 women died in 2015 as a result of pregnancy-related conditions. But 5 times more women knocked the door of death but came back. That is what we must try to increase. We must avoid the maternal deaths. And to avoid maternal deaths, the only way is to find out which are the causes that pushes them almost on the verge of death. Here is a maternal mortality in South India. This was a couple of years ago. Kerala now has improved to 30. Tamil Nadu also has improved. Telangana 81. Andhra Pradesh and Karnataka 108. The national average is again has improved now. It is somewhere around 100 plus. And then in some states, it is still up to 300. Manipal is situated in a district called Udupi, and the maternal mortality in Udupi is 1.3 per 100,000. That is comparable to any first world countries in the world. And in KMC, I'm very pleased to say that it is 0 among the booked cases. Of course, we had maternal deaths in our hospital, but all of them were referred from other districts, not from our booked cases. We have been able to improve ourselves because we have been doing this maternal near-miss audit for a long time now, more than 10 years, ever since it was introduced by WHO. It's the need of the hour. That's the only way we can reduce maternal mortality further down. What is near-miss maternal morbidity? In 2007, WHO established a technical working group comprising of obstetricians, midwives, epidemiologists, and public healthcare professionals to develop a standard definition for this and uniform identification criteria for maternal near-miss cases so that the audit goes on uniformly and hence the interventions as well. Near-miss is a condition of a woman who almost died during pregnancy, childbirth, or 42 days postpartum. Can you make out that the definition is almost like maternal mortality definition, except the word almost died? Events that would have resulted in maternal death during pregnancy and childbirth, if not for significant medical intervention. This is another way of putting it in the same way. Whatever it is just that she would have died, but for a timely decision, timely intervention, like that pilot in the nick of the time, he aborted the landing and decided to take off again and averted a disaster. It's more in high-income countries. That's because they have now achieved almost very in single digits the maternal mortality. That's why they are now concentrating on near-miss cases, and you can see them high there. In low-income countries, mortality is more, and there are more than mortalities in high-income countries. Why should we do this audit? The near-miss and maternal mortality have similar pathology and complications of pregnancy. That is the reason. So if you don't intervene, the same pathology will push her into the teeth of death. By evaluating these, much can be learned about the causes and the processes in place so that we can avoid a preventable death. The utility is to determine the frequency of complications, which are the indirect indicators of maternal deaths, to provide information on the quality of maternity care for life-threatening complications, to evaluate healthcare facility and interventions, and it raises the awareness, it fosters the changes towards improvement of maternal health care. Later, when I present the Manipal statistics, you will clearly understand how we have improved over the years because we looked inwards. We did this audit. What is a concept and principle? The concept is that there has to be a criteria, and based on that criteria, we have to do an honest clinical audit. The principles are, it should be easy to use criteria. There should be actionable results based on that criteria. For example, if the criteria says, if the lady wants blood transfusions more than certain number of pints, then we should be able to provide that everywhere. Cost effectiveness. It should not be very expensive interventions, or we should be able to have a standardized type of intervention. What are the assumptions? All maternal deaths involve at least one life-threatening condition. We can say organ dysfunction. Otherwise, death is not possible. So this is the basic assumption that whenever a mother dies, definitely there would be an organ dysfunction. Usually there will be multiple organ dysfunction, but at least one organ dysfunction, one life-threatening condition will be there. A substantial portion of them have severe pregnancy-related complications. For example, severe PPH or severe preeclampsia. So organ dysfunction due to at least one severe pregnancy-related complication. Of course, medical complications also can kill a mother, which we call indirect cause of death, but definitely in majority of the cases of mortality, there will be one severe pregnancy-related complication. You will see that again when I present the statistics of Manipal. Or she has received clinical interventions such as ICU care or blood transfusion. The common criteria for near-miss cases are a multi-system failure or severe dysfunction. Just as I said, reiterating the same fact. Respiratory, cardiac, renal in single or in combination. Need for major intervention or interventions or resuscitation. For example, intubation, blood transfusion, component therapy, hysterectomy, emergency hysterectomy, or ICU admission. And a serious category of disease, for example, severe hemorrhage or severe eclampsia. Let us now look at in detail criteria. What I told you in the previous slide is a broader idea that one severe organ dysfunction or one severe major problem or a very grave intervention. These are very broad headings, but let us look at individual criteria, organ-wise or lab-wise or intervention-wise. WHO has beautifully laid down these criteria. The critical interventions or ICU use. It could be just an ICU admission, even if it is for a few hours, or use of blood products, FFPs, platelets, or cryoprecipitates, or even packed cells. Interventional radiology, maybe uterine artery embolization, is a life-saving procedure in PPH when the patient is stable. Laparotomy, maybe for an hysterectomy or even an emergency cesarean section followed by hysterectomy. But if you just do a cesarean section, it is not a critical intervention. Maybe it is a critical intervention to save the fetus, but not for the mother, unless she has gone in for an obstructed labor where she has ruptured the uterus. You have done a laparotomy, not cesarean section, delivered the baby may be alive or dead, and immediately you follow it up with a hysterectomy. That is a critical intervention. The life-threatening conditions, let us look organ-wise. Cardiovascular first. That's the most important. Shock. It could be hemorrhagic shock, hypovolemic shock, just a cardiac shock. Cardiac arrest due to any reason. It could be severe hypovolemia or any other myocardial infarction, anything. Or use of continuous vasoactive drugs to keep up the blood pressure. Cardiopulmonary resuscitation. She would have just had a cardiac arrest and you would have done a CPR. Severe hypoperfusion, where lactate is more than 45 milligrams per DL. There is severe acidosis as indicated by pH less than 7.1. After heart, usually we go to the adjacent organ, that is lungs, respiratory system. Acute cyanosis. It is usually rare in pregnancy, but if it happens, that means it's a life-threatening condition. Gasping, patient is asking for more breaths. There's air hunger. Severe tachypnea, more than 40 breaths per minute. Severe bradypnea also, less than 6 breaths per minute. Intubation and ventilation, not related to anesthesia. It's not that they didn't reverse the anesthesia, that's why she's continuing with the intubation. You have done a deliberate, purposeful, life-saving intubation. Or severe hypoxemia, oxygen saturation less than 90%. All of us are now aware because of this COVID about oxygen saturation. But here, the criteria is that it should last for more than 60 minutes. After heart and lungs, the next two, these are in the chest cavity, 2 organs. And now come to abdominal cavity, 2 organs, hepatorenal. Hepatic, jaundice in the presence of preeclampsia, which already means that there is HELP syndrome. She has gone into severe preeclampsia. Severe acute hyperbilirubinemia, either could be due to preeclampsia or could be to fulminant hepatitis of the pregnancy, jaundice of pregnancy, where bilirubin is more than 6 milligram per DL. As far as renal is concerned, oliguria, which is non-responsive to fluids or diuretics, usually cold stage of sepsis leads to this, or severe abruption, severe hypovolemic shock. Dialysis for acute renal failure. I other day was taking a class, whatever may be the reason for acute renal failure of pregnancy, PRACI, or severe acute azotemia, wherein creatinine is more than 3.5 milligrams per DL. Anything more than 1.1 is positive or critical, but anything more than 3.5 is very severe. Then we have our accompanying problems in pregnancy, coagulation problems. Now, notorious one is that consumptive coagulopathy of abruption. Failure to form the clots, massive transfusion of blood products more than 5 units, maybe cryoprecipitates, maybe FFPs, maybe platelets. Severe acute thrombocytopenia, which happens in again HELP syndrome or even due to any other medical conditions. Coming to uterus, hemorrhage or infection leading to hysterectomy. Neurological, which is not very common, but there also you can have prolonged unconsciousness after a status eclampticus lasting for more than 12 hours, or coma, including metabolic coma, stroke, or uncontrollable fits or status epilepticus, or total paralysis. To summarize the same criteria, we looked at organ-wise, 2 organs in the chest, 2 organs in the abdomen, of course, the uterus, the main organ, and then one system problem, that is coagulation failure, and then very rarely neurological problems. To summarize them, we have criteria divided to clinical criteria, which means shock. That shock could be anything, cardiogenic or due to postpartum hemorrhage. Oliguria, unresponsive to fluids and diuretics. Loss of consciousness for more than 12 hours and seizure. Jaundice with preeclampsia, clotting failure, and acute cyanosis, gasping. So as you can see here, shock represents cardiovascular system, oliguria represents renal system, consciousness, neurological system, jaundice is liver, clotting failure is coagulopathy, and gasping is respiratory system. Yeah. So after this clinical criteria, let's go to lab criteria. Now, correspondingly, oxygen saturation less than 90% or for more than 60 minutes is depicting respiratory system. PaO2 by FiO2 less than 200 milligrams, again suggesting the same thing. Creatinine more than 3.5 suggesting the renal failure. Bilirubin more than 6 suggesting hepatic failure. pH less than 7.1 and lactate more than 5 suggesting metabolic or respiratory acidosis. Platelets less than 50,000 suggesting there is severe preeclampsia. Then we have interventional criteria or management criteria. Whenever there is shock, you would use vasoactive drugs. Hysterectomy you may be undertaking due to infection or bleeding. Transfusion of red blood cells whenever there is hemorrhage, more than 5 pints. Intubation, mechanical intervention for more than 60 minutes for respiratory problems. Dialysis for acute renal failure, and cardiopulmonary resuscitation. So this is the criteria, elaborate one. But if you tell me it is so much in detail, yes, when you do a study, when you do a thesis, when you do yearly audit, it is possible. Go by strict criteria. But when you have a case on the hand, quickly how to recognize this is the lady who belongs to near miss situation, and if I don't intervene now, I may lose her. There is a simple 5-factor scoring system, which is 100% sensitive. That means you will not miss a single case of near miss. And it is specific for 93%. Specificity is 93%. What are they? Number 1, any transfusion more than 4 units is a near miss case. 1 or 2 pints is usually we do. But if a patient needs more than 4 pints, anything, it could be packed cells, it could be cryoprecipitates, it could be platelets, she is a case of near miss. You can include her in the audit. ICU admission, simple criteria. Obviously, patient will receive inotropes there. She may be intubated there after going to ICU. Sure enough, intubation is the third criteria, more than 12 hours. Organ failure, it could be renal failure, liver failure, respiratory failure, cardiac failure, or coagulation failure. Any one failure. And unanticipated surgical intervention, something like UAE or hysterectomy, or maybe draining of the pus and things like that, or laparotomy, maybe for doing a internal iliac ligation. So this simple 5 criteria and 4 of them are usually we come across the surgical intervention is not very commonly done. Now, again, if you tell me 5 criteria is also too much, are there any just 2 criteria? It's like phone a friend or 50-50. You remove 3 and make it 2. Yes, 2-factor scoring system is also there, wherein you remove these 3, just 2. Transfusion more than 4 pints of blood, ICU admission. ICU admission automatically means there will be use of intubation. There will be use of ventilators. There may be use of inotropic drugs. There may be use of some interventions, dialysis. There may be hysterectomy. So it has got again 100% sensitivity, but specificity comes down to 78%. Now onwards, it should be very easy to pick up the cases of near miss. Just 2 criteria: ICU admission, transfusion more than 4 pints. What are the 3-step approach? In a cyclical manner, first one is baseline assessment, quick assessment, or even reassessment. Second, situation analysis. Can we shift her to ICU? Do we have ICU? Can we do hysterectomy now? Can we take her for uterine artery embolization? Quick analysis of the situation. Number 3, actual intervention for improving healthcare. So let's look at each one of them. Baseline assessment includes near miss criteria is applied based on the clinical audit, and healthcare consumes near miss women, providers, and managers' views. And situation analysis includes identification of opportunities and obstacles for improving care, whether you have capacities in your place, whether it is secondary hospital, tertiary care hospital, whether you have facilities of blood bank, anesthesia, hysterectomy, things like that. And then comes implementation of tailored and multifaceted intervention for improving care, audit and feedback, engagement of opinion leaders and early adopters, and development and use of local protocols, prospective case identification, reminders and educational activities, and finally use of evidence-based checklist. Now, it's very simple and easy to collect the data. There is a already link, WHO link. This is the link which you can click and you will get this kind of a form automatically. This has got all the details. I don't have to explain that. It is self-explanatory, very detailed information. You have to just simply tick or just choose very simple form, and then you will know. The sample size, how many times, how many cases should be there to do a maternal mortality or near miss mortality audit. Mine is a small nursing home of, let's say 50 deliveries per month. Can I do near miss audit? Answer is yes. It need not be a big hospital. Everybody can do an audit. Minimum sample size for producing near miss and process indicators has not been established. However, the expected numbers are all eligible women as per criteria. At least you should have around 37, and then severe maternal outcomes 7.5 per 1,000 deliveries. Sample size should be calculated based on prevalence in a given center. What are the indicators of near miss? This is very important. Just doing the cases audit and is not very useful. You have to calculate these ratios. When you calculate the ratios, then only you will know whether you are improving or not. These are not very difficult at all. Let me go slowly and explain this. The maternal near miss ratio simply means number of near miss cases based on the criteria that we have used. How many cases required ICU admission? How many cases required 4 pints of transfusion? How many cases had renal failure? How many? So like that, totally, how many cases were there which can be categorized as near miss cases per 1,000 live births? Very simple. So on the numerator, near miss, denominator, live births. But this is very important. women with life-threatening conditions, sum of maternal near miss plus maternal deaths. Here you take both, because this life-threatening condition can kill a mother. Out of them, some of have been saved. But when you talk about women with life-threatening conditions, you should include both those who died as well as those who were saved. So WLTC is equal to maternal near miss plus maternal death. Yes, both of them were very simple, but here comes maternal near miss mortality ratio, not near miss ratio. It is near miss mortality ratio. This is very, very, very important. It is a ratio between near miss cases and deaths. How do you calculate that? On the numerator, you have near miss cases. On the denominator, you have actual deaths. So it's very easy to guess. Higher the ratio, it is better, which means there were less number of deaths in the denominator, more number of near miss cases in the numerator. Obviously, the ratio will be higher. But if there are more deaths in the denominator, a less number of patients you saved them, near miss cases, obviously it's not good. I'll give an easy example. Let us say there were totally 100 near miss cases and we had 10 deaths. So on the numerator 100, on the denominator 10. So the near miss ratio is 10. Another case situation, near miss cases were 100, but we had 25 deaths. So obviously the ratio will become 4. Lower the ratio, it is bad. That means there were more deaths. I hope it's very clear. Then there is something called mortality index. How do you calculate that? Number of maternal deaths among women with life-threatening conditions. You remember a slide before previous one I told you, WLTC, that is women with life-threatening conditions. That means those who were saved plus those who died. Both together is women with life-threatening conditions. Among them, how many died is mortality index, and it is expressed as percentage. Here it is. On the numerator, how many died? On the denominator, died plus saved. So what should be and it is expressed as percentage. Lower the better. Lower the better. That means you had a big pool of patients who had near miss cases. Among them, only few died. So high means if the numerator is more, many people died, means your quality is very low. I'll give the example, same example I will use. On the maternal near miss, we had 100 cases. Maternal death, we had 10 cases. Now, maternal death will go to the numerator. The total number of cases will come to the denominator. And it is multiplied by 100. So, the ratio is 10. Whereas, if there were 25 deaths among all these cases, then your ratio becomes 25, which is bad. So lower the better when you talk about mortality index, but when you talk about near miss and mortality ratio, index is different, ratio is different. When you talk about the ratio, higher the better. Lesser the deaths, more number of cases. It's the same thing. More number of cases of WLTC, but lesser deaths. There also more number of near miss cases, but lesser deaths. So one is a calculation, which is a ratio, should be higher the ratio. When you talk about index, the index should be lower. Now I will give you what we have done in Manipal. This is the older one, which has been published already, 2011 to 12. As you can see here, a whole lot of it. Dr. Pratap Kumar is there, myself and Dr. Jyoti and Rupa, every one of us are there in this. It has been already published. Then further, every year we are doing this, I told you. Then we did this kind of a calculation. This is to be published. We wanted to have more of them. 2017, and we compared that with the previous 2 years together, 2015 plus 16. What is written in gray in the bracket is 2015 plus 16. What is blue is 2017. The total number of deliveries were 3,055 in 2017, whereas the previous 2 years together was 4,483. Obviously, our number of deliveries were increased in 2017 from 2,037 in the previous years to 279 per month in the 2017. The near miss cases in 2017 were 50. Among them, only 6 were booked, 44 were unbooked cases from other districts. In the previous year, same thing was 78 cases totally, and booked were 13, unbooked were 65. Maternal deaths, we had 7. I told you, none of them were from our booked case, from our Manipal. All the cases were referred from outside. And in the previous 2 years together, there were 19 cases. So this is the figures. Now, how to calculate the ratios, I will tell you. Now, first we'll see the maternal near miss ratio, which simply means on the numerator, total number of near miss cases, on the denominator, total delivery. Then you will get how many per 1,000. Well, this is just to know, as it increases, it is increasing. As it decreases, it is decreasing. The previous year, it was 17.3. Obviously, it was decreased in 2017. This is very, very, very important, I told you. That is maternal near miss, not simply ratio, mortality ratio. That means out of the near miss, how many were saved, how many died. So on the numerator, you have near miss cases, denominator, you have deaths. We had 50 near miss cases, 7 deaths. So the ratio becomes 7.1:1. The previous years, it was 4.1:1. Higher the ratio, better. Remember that. Higher the ratio, better. Whereas mortality index, when we say, out of the total women with life-threatening complications, that is deaths plus near miss, 50 plus 7, 57. On the numerator, only deaths multiplied by 100. It becomes 12.2. And this should be higher or lower? It should be lower. The previous 2 years, it was 19.5. And this 2017, it was 12.2. This clearly tells us that our systems are working. Our audit is working. We are improving. So that is what I told you. When you do the audit only, you will know what is happening. Now let us look at what were those near miss cases. In 2017, we had actually out of 50 cases, 12 cases were, let's say, preeclampsia, or 42 cases were hemorrhage, and preeclampsia were 18, sepsis were 28%, and others were 12%. In the previous years, as you could see here, hemorrhage was almost similar. Preeclampsia was more. Probably our interventions, early interventions, they were less. Sepsis, in fact, actually increased in the 2017, and others were almost similar. Let us look at the near miss cases. What are the cases we actually had? If you simply say hemorrhage, what type of hemorrhage? Atonic or traumatic PPH with DIC we had. Placenta previa, accreta, percreta, abruption cases. Ruptured ectopic. Yes, ectopic is also considered as near miss situation if you had to transfuse, because you remember the definition says almost same as maternal mortality during pregnancy, and not only that, 42 days after their delivery or abortion. Only difference is patient didn't die, we saved her. Preeclampsia, eclampsia, HELLP syndrome, renal failure. H1N1, respiratory problems also were there among the near miss, pneumonia and other ARDS. Dengue, meningitis, Krebs typhus, and other sepsis. And AFLP, ITP, cardiac failures, and cardiomyopathy. These were the cases of near miss. What are the interventions we did? Hematoma evacuation, vaginal laceration repair under GA, laparotomy followed by salpingectomy or internal iliac ligation or hysterectomy, massive transfusion or inotropic support in the ICU, hemodialysis and plasmapheresis whenever there was renal failure, tracheostomy, intubation and ventilatory support for all ARDS, uterine artery embolization when the patient was stable, magnesium sulfate infusion, neurological support. So these were the interventions that we did in 2017. Now let us look at those 7 mothers who died unfortunately. What were the situations? And in the previous year, when they died, 19 cases, what were the problems? As you can see here, preeclampsia was only 14.3%. That's only one case. There was no case of hemorrhage with good intervention. No cases of other conditions. The main cause was sepsis. 85.7% of the cases. When the patients were referred to us in full-blown sepsis, they were almost dying. And they were resistant to all the antibiotics, even including meropenem and everything. 6 deaths were due to sepsis, which is definitely preventable. We should be able to prevent such cases. Maternal mortality index of causes. That means if you had 100 cases of one particular problem, how many of them died? Preeclampsia. How do you calculate that? Same thing. Near miss cases plus death in that particular condition, you will together put as the maternal mortality index in that particular disease. Suppose you had 100 cases of preeclampsia, how many of them would die? 1.9% would die in Manipal. We have to reduce it further, of course. In the previous years, it was 3.7%. So obviously we can see that it is better. Lower the better. When we talk about index, lower the better. Sepsis, we had totally 50 near miss cases and 6 cases of death together, that is women with life-threatening conditions. So deaths will go to the numerator. Near miss plus death will go to the denominator in that particular condition. So if you have 100 cases of sepsis, there's a good chance of 10 of them dying in Manipal. But we have to improve that. So it was slightly more compared to the previous 2 years. Previous 2 years, it was 7.1% increase. Of course, it is not because the sepsis happened in Manipal, but these were the cases, more number of cases were referred to us. So this clearly tells us how and where we should improve, where we should concentrate. And we have to educate the people who are referring to us. We usually write a letter to them and tell them that probably they should have done this, probably they should have done that. It's not to blame them. It is all in confidence. It is just to improve the situation. Hemorrhage, we never had in 2017. Others, we didn't have in 2017. That's why both are in gray. Previous year, hemorrhage was there, 4.9% was the index. Suppose 100 women had hemorrhage, only 5 of them would die. That's the meaning of this. Other causes, if there are 100 cases, 7 cases would die. So we thank Team Manipal, Department of Critical Care, ICU, nursing staff, transfusion specialist, hospital infection control division, physicians, internal medicine, nephro, neuro, cardiologists, surgeons, general, uro, and CTS, and all that are not mentioned here. Because of their support, cooperation, teamwork, we could save mothers. Together, everyone achieves more. All of us know that. So in Manipal, what we do is whenever or where maternal deaths happen, OBGYN HOD is informed immediately. Sometimes mothers directly go to medicine and die there. So OBG HOD is informed immediately, and we submit facility-based maternal death information is sent to district health officer within 24 hours. Whether there is a delay in seeking, whether there is delay in transport, whether there was delay in initiation of treatment. All of us know this, 3 delays. And first of every month at 12 o'clock sharp in medical superintendent's office, there is a maternal mortality. If there are no mortalities in that particular month, near miss cases are discussed. And everybody, every single PG knows the criteria. I told you 2 simple criteria. 4 pints of blood transfusion and ICU admission is enough to categorize that patient as near miss case. Then we discuss in details. Maternal mortality meeting at DHO office and DC office every 2 months. And we are really taken to task by the district collectors. And we have to answer them every detail, as though, we have neglected the case, as though we have killed the patient. So such thorough scrutiny happens. And that's where we are extremely, extremely careful. So what happens usually, HOD or duty medical officer identifies near miss case as per the criteria laid down and records it in relevant register. He completes that FB MNR R form and sent to the MNR nodal officer of the facility within 48 hours of the patient discharge, ensuring no changes are made on the case sheet. That is criminal mistake. We can't do that. And to ensure near miss formats are filled in the discharge case as well. And then HOD or medical officer will inform the medical superintendent, who in turn will inform the district nodal officer, and facility-based nodal officer is informed directly by the HOD or through the medical superintendent. State nodal officer is also informed about it. Karnataka government has given us this detailed form, which we have to fill whenever there is a near miss case, then and there only, and we have to inform. So from mortality information, we are now switching over to even near miss information. That is the way we have to work, and only then can we bring down the maternal mortality. We should not wait till the mother dies and then inform and then do postmortem and then discussion. Even a near miss case should be discussed then and there only, every month. So thank you very much for the opportunity given to me.
So it was really a wonderful presentation, and the hard work that we can see behind this of your last decade and years together and put it in a reality. It's something very exemplary. I think tribute will be if every medical college implements this, then I think I can imagine what can happen in our country in bringing down the mortality. Wonderful. Just I have no words to thank you for everything. The way, in a lucid way, you have just conveyed the message. I think this is very eye-opener presentation for every gynecologist. Why medical colleges? Every gynecologist. That it is a near miss reference is more important rather than actually mortality and then doing postmortem.
Yes, sir.
Thank you very much, sir, for highlighting the importance of near miss cases, that we have to audit ourselves, and as you said that there is no limit of sample size of doing the near miss case audit. Even a small nursing home in our country, because in our country most of the deliveries, majority of the deliveries are doing in private nursing homes. So we can learn so much from this, that near miss cases audit is very, very important to save the life of the mother and to reduce the maternal mortality rate. In our Gujarat, sir, we are now proud to say that we have reduced the maternal mortality rate to 75, and
Excellent.
I think it's recently it is around 60, I think. So and in 2030, the goal of the maternal mortality is around I think 30. So by doing this near miss case audit, we can achieve this goal, and this is a very important hints and the tips to the audience and who are listening this oration. I think this is the wonderful presentation for this to reduce the maternal mortality rate. So thank you so much, sir,
Thank you,
for
sir.
giving this opportunity to our society to give the oration by you. And I would like to invite Dr. Dipesh Dholakia, who was the organizing chairperson in this AICOG, which was held in Ahmedabad, and he is the main rescuer in our Ahmedabad city. In there, he is going to everywhere to save the mother in emergency situations. So I would invite Dr. Dipesh Dholakia, sir, and give some tips to the audience also.
Hello, good evening, sir. Good evening, Murlidhar,
Good
sir.
evening, sir. Good evening, sir. Don't call me
as-
sir, sir. Call me Murli.
Yes, yeah. As such, I am just now in operation theater, and just we are referring one patient, which is just near miss case, because
sir.
that patient having a normal vaginal delivery, and after that she had a DIC. So all the factors are disrupted. So we have managed all this. We have given 4 PCV and FFP and cryo, all these things. And we have packed the vagina, and from everywhere the blood is coming. Now the patient is little bit settled, but we have given all these things. So we do not want to take the second chance. So now we are referring that patient to higher centers.
Yes, sir.
So our aim is to send the patient when the patient is in stable conditions.
Correct, sir.
Yeah. So that in Ahmedabad, most of the setups are private setup, and 1 or 2 gynecologists managing such type of
Very
patient,
difficult, sir. Very
and
difficult.
it's very difficult. So what we are the rescuers. We rush to such a private nursing home to make the team, and we settle the patient. We do whatever the possible in the private setup, and ultimately, if the patient is stabilized, and for further management, we either refer it to HDU or higher centers, or in the government setup, or some ICU setup. It requires the teamwork. It requires lots of efforts by we gynecologists and obstetricians to save each and every patient. So even a single mortality, we cannot tolerate these things, and it is our aim to save every mother. Not a single mother should die in pregnancy or pregnancy related complication. Sir, you have done throw light on so many factors, and it is our aim now to decrease this maternal mortality rate. And even Gujarat is doing well, but in every states we should have HDU and ICU and backup facility to save such near miss cases. Thank you very much, sir, for your wonderful orations. And I think we also get very good messages from that, and we apply all these to decrease our maternal mortality rate. Thank you very much, sir.
Thank you, sir.
Munja.
Yes, sir. So we would like to have the memento to be read by Dr. Jignesh Deliwala, sir, President AOGS. Jalakban, can we display the digital copy of memento, please?
Sir,
Yes, thank
this
you.
is hard copy of memento, and just I would like to give this memento to Dr. Murlidhar V, The Ahmedabad Obstetrics and Gynecological Society feels honored and has pleasure to award AICOG 2017 Oration for the year 2021-22 to Dr. Murlidhar V on 26th March 2022. And the subject is maternal near misconcept and audit, need of the hour to bring down the MMR in India. Sir, this is a memento we will deliver to your home as early as possible with the scroll. So thank you, sir. Thank you very much for remain present this for oration. And we thank, and I think this oration will be uploaded on our website also. And we will be a great privilege for that. Thank you. Thank you, sir.
Thank you, sir.
Thank you very much, sir, for your precious time. Thank you,
Thank you,
sir.
sir. Thank you.
Thank you. Thank you so much.
Thank you. Shall we log out now?
Yes, sir.
Yes.
Okay, thank you.
Thank
Bye.
you so much, sir. Thank you.
Thank you. Okay. Good night.
Good night.
Good night. Good night.
Good night.